Yes, sir. Then the window will
Entire
pop up.
screen.
Yeah, your entire screen. Under that, you can see the small screen. Click on that, then click on the share button.
1 second. Yeah, sure. That's right.
Yes, sir. Perfect. Now just need to go to the presentation.
Yeah. Is it on?
Yes.
Can we see it?
Yes, you can see it now.
Yeah. Okay. All right. So this is a 75-year-old lady, which I would like to present. She's a hypertensive and had angina class 2 for about 4 months before she presented to us, and that which had progressed to about class 3 since 2 months. So she was advised an angiography, but she didn't go ahead with the angiography. And she was admitted at 1 a.m. in October 2018 with sudden onset of chest pain, sweating, and dyspnea at rest. So when she came into the hospital, she was tachycardic with a heart rate of 110, the blood pressure 120, respiratory rate was 28, and she was in failure. And her SATs were about 92% on room air. She was otherwise conscious oriented, and this was her ECG on admission. So it showed broad QRSs in the sense she had a right bundle branch block and she had ST elevation in OVR. She obviously was in left ventricular failure, and so a diagnosis was echo was done, which showed a global hypokinesis with EF of 30%. There was a moderate MR and with moderate pH. Her troponins were sent, which rose from 318 to over 2000. So she was diagnosed to have an acute coronary syndrome with left ventricular failure, stabilized with BiPAP support and diuretic infusion, started on dual antiplatelets, low molecular weight heparins, nitrates, and statins. Once she was settled, we did an angiography in the morning, which revealed this was an angiography. Her left main was heavily calcified. The distal left main showing about 60% stenosis. Her ostial circ and LAD were also calcified. Ostial LAD had critical 99% stenosis. Her circ was dominant and was calcified. There was a critical 95% stenosis at the ostium and proximal segment, about 75% stenosis after the large OM. And her this is the another view of the LAD showing the critical lesion and calcified nature in the LAD. The RCA was non-dominant and normal. So after this, the syntax score was 34. Syntax 2 showed that the PCI score was 43.8. CABG score was 33. So we recommended that she undergoes a bypass surgery. The patients and the relatives were counseled. The relatives and the patients flatly refused. They said they would not undergo a CABG. So she was then planned for an angioplasty. The plan was to proceed with left main because this is like a distal left main, Medina 111, and with calcification. Plan was to go ahead with rotablation followed by a stenting of the left main and the ostial of the LAD and LCX. So she was taken up for an angioplasty. Left main was cannulated with 7F EBU. LCX was wired with a double length wire and was exchanged to a rota floppy wire with the help of a microcatheter. So we took a 1.5 rota burr. The initial plan was to do the circumflex because the circ had two angles, one at the ostium and then subsequently at the bend where it turns over just before the OM1. Plan was to do small burrs because there was going to be a wire bias, and we felt that the circ would be more challenging compared to the LAD because the LAD was relatively straightforward. So we wired and started off with started the rotablation for the circumflex and started with small pecking motions to the ostium. And once that was done, the plan was to then advance the burr and go over that angle and then go down into the circumflex. So after the initial part was burred, after it took the angle, there was the burr jumped and then it got stalled in the mid segment of the circumflex. So we tried. The patient at that point of time complained of chest pain, developed hypotension and bradycardia. I always put an I always take a venous access, but not put a wire, temporary wire, except for an RCA. I definitely put in an temporary wire, but in this case, we're just taking a venous sheath. So we put in the temporary wire, and inotropic supports were started. We tried to pass a wire by the side of the burr, but could not do so. Tried to increase the rotation, increase the burr speed to try and release that burr, but that did not release the burr. The next, we were wondering what's to be done because the patient was hypotensive. So the other options that we had was to cut the rotational wire and get a guide extension and then to pull it out. But to our favor, the left main was very roomy. So I said, before we try and dismember the rota, we deep throated the guide and gave a manual traction. And with that, luckily for us, the burr could be retrieved. Once the burr was retrieved, we took a check angio. And now we saw that there was a dissection at the ostium of the LCX, and that dissection was then now extending back into the left main. So this is a setting for a perfect storm. We have a distal left main dissection, the circumflex which is dissected, and we still have an LAD ostium which is calcified, still needed treatment for rotablation and needed treated with a rotablation. So we have a 7F guide. So initially the plan was to try and stabilize this patient. So I wired this wire. Plan was to wire the circumflex, keep a micro catheter, and then try and do a rotablation to the LAD. So we wired the circumflex, got a micro catheter, then exchanged, wired the LAD and exchanged that to a rota floppy wire. And then at that time I realized that the guide, which was a 7F guide, wouldn't take my micro catheter and my rotablation, rota burr. So I needed something which was more than 8. So the issues were, one, I had to either remove the wire and lose access to the circumflex, which we had got through, or the other, and or to upgrade this. But upgrading it and going from the opposite side would have been more cumbersome. So since we had got in once, we said maybe we'll get back the second time in. So we removed the wire from the circumflex and then proceeded for rotablation to the LAD. So used the same burr and we did the rotablation, and post rotablation we rewired the circumflex. Luckily we were able to get back into the true lumen, and once that was done, we took a 2.5 by 15 millimeters balloon and pre-dilated the LAD ostium. The plan was to see whether I was able to expand that balloon. If it was not, then I would have used a cutting balloon to try and increase the lumen and prepare the bed well for the LAD. But luckily for us, the balloon opened up in its entirety. So we were comfortable that this lesion would. The LCX was not pre-dilated because I did not want to extend the dissection. So once this was done, now we had to decide our strategy. The patient was hypotensive, had a lot of tachycardia, still complaining of pain, and the dissection was extending back to the left main. So, and trying to go for the other strategies would have again extended my procedure. So this point of time, decided to go for an SKS. So took a 3.5 by 24 millimeters drug-eluting stent and placed it from the left main into the circumflex. We didn't have another of the same family, so we used another 3.5 by 23 millimeter stent from the left main into the LAD. Both stents were placed from the body of the left main, covering the dissection, and were extending into the distal LAD, into the LAD and the circumflex. Positions were checked in different angles, and once they were placed appropriately, both the stents were deployed at 14 atmospheres simultaneously, and both the stents were dilated separately at 18 atmospheres each. Once this was done, you can see there is a visible reduction in the heart rate the patient's blood pressures, hemodynamics improved, the chest pain was relieved. So then with that, the balloons were then removed, and we used, we did a pot in both the LEDs by using 4x12 NC balloons in both the LED as well as LCX, and we went up to 20 atmospheres. The final results, the heart rate settled, the blood pressure improved, and the patient was symptomatically better. And she was in her own rhythm. She was shifted to the CCU, and the ECG also stabilized. These were her pictures post deployment of the stents from the left main to the LED and the circumflex. This was the ECG on the 16th. You can see that there is a visible narrowing of the QRS. There still is a right bundle. The STs have settled down, because this was like a left main equivalent. So, and the QRS normally would become broad. Here, the QRS, once the ischemia has been taken care of, the QRS width has narrowed. This was the echo on follow-up. It showed concentric LVH. The LV had improved. It had gone up to 60%. The MR had come down to grade 1, and the pulmonary artery pressure had come down. The last follow-up was in Feb 2020. The patient was asymptomatic at this point of time. So I know that SKS is usually not to be, not an option in the routine cases, but in case of emergencies where we would definitely need to, salvage the situation like we were in, where the patient was critical and there was no option for a CABG, or the patient was also not willing for a CABG. I think an SKS can be used to bail us out from this situation.
Wow, Dr. Prasad, that really required. I was getting tachycardia looking at you doing the procedure, looking at the angio runs. I think there was a great save, and I think what you did in a SKS, whatever you talk about in SKS, I think that was the only feasible thing to be done for this particular case. No points, I think, in this was the fact that you still did go for a rotablation to the LED despite there being a dissection from the left vein into the circumflex. That I think was very good, because the left vein is roomy. Though we say that a good learning point there, we say that the dissection is a relative contraindication for a rotablator. In case you do it carefully and you got a room left vein like this, you really wouldn't cause a problem. But having said that, dominant complex, I think it was a good chance that you took and a good save. The angiogram that you showed is classical of a calcific nodule sitting at the bifurcation of the left vein into the LED and circumflex. And that's a typical picture of a huge calcific nodule. Very difficult to treat with PCI. Even with a rotablator, it's a very difficult lesion to treat. And I think I wouldn't do it any differently from what you did.
Prasad, just a couple of questions. One is, if suppose everything had gone well, you had rotablated the circumflex, and then you plan to rotablate the LAD. What was your plan of? How would you have gone ahead planning the stenting technique?
So in this case, if you see, the left main was very roomy, it's very large, and the distal left main was tapering. The plan was rotablation and V-stenting, because if you see, there was a lesion which was there in the distal left main, which was roomy, and the plan was just to do a V-stenting at the LAD ostium and circumflex ostium.
Okay, there's the only other comment that I wanted to make was, I don't know, when we first started doing rotablators, we never used to do the pecking, the fast pecking technique. It used to be always a slow progression of the burr to get a good cut across the lesion. This fast technique of fast pecking has come in recently in the last couple of years from a few operators from the West. When you do a very fast pecking motion, especially with a 1.25 millimeter burr, and especially in a circumflex where you can expect that there's a posterior takeoff and another bend, the chance of burr entrapment are much higher, because the burr slips through without cutting, and then you find it difficult to retract the burr stalls distally, you may be able to avoid it by using a probably larger size burr, a 1.5 millimeter burr, and a second is a good guiding support. Your guiding was slipping back whenever you were rotablating the circumflex. So ensure that your guiding is good, and a slow burring across the circumflex. And another point, which again I'm not sure whether it holds good on all patients, is in such situations, it probably is better to burr the LAD first and then burr the circumflex, because two things. The chances of complications or dissections are much higher in the circumflex ostium, like you said, because of the takeoff of the circumflex, and the chances of certain and any difficulty in rotablation is much higher with the circumflex. So, the chances of rewiring the LAD without a problem are much better because of the takeoff of the LAD. So the chance of getting into issues rewiring the LAD are much lesser. So you all try and rotabate the LAD first, then go for the circumflex, because then the circumflex wire is always there in position. You don't lose the position of the circumflex wire. So just two things which came to my mind, but otherwise an extremely good save. There's a question by Dr. Hasmukh Rawat: is there a pot in an SKS technique? But I think you used the bigger balloons there because the left main was very roomy. You had to make sure the stents were deployed well. Yeah, well opposed onto the wall.
The other thing about this fast pecking is actually was doing the slow pecking with the circ, but I had tachycardia. The patient had tachycardia. I had to open up that well, so I had to just open up that LAD before. So whatever came, I took it, and that's the reason I did a balloon validation subsequently. That if it was not opened, I would have used a cutting balloon to try and open up that LAD lesion. But the point's valid. So next time situations would go to LAD first and then the circ.
Ajit, I have a question regarding this rotablation. Now, in a situation like this, when it's a calcific module, would you prefer to do a rotablation in this case, or would you like to debulk with some other method like boring balloon or something? Because calcific nodule is very difficult to handle. And the second point, I would also ask you, would you would you put a microcatheter in the other vessel when you rotablate the second vessel?
Yeah, two things. I mean, coming to the first question, if you don't have an imaging, if you're going in blind, then I would definitely rotablate the vessel. But we always tend to use a scoring balloon to post dilate the lesions, because we don't know what is the anatomy inside. We don't know what sort of calcium do we have. So you really end up with an underdeployed stent or an underexpanded vessel. If you have an imaging, you'll know it's a calcific nodule. If it's a calcific nodule, probably it's better to use something else rather than a rotablator under those circumstances to get and today you have IVL, etc., to get a good dilatation, a good cut, a good this thing inside, and deploy the stent. Secondly, I would definitely not keep another catheter inside when you're doing a rotablator, because inadvertently, if the burr comes into contact with that, here of course the left main was roomy, so probably chances are less, but it's taking a risk. The burr can cut it, and you may end up with a cut catheter inside the vessel. So keeping another catheter in or a wire in when using a rotablator is I don't think is advisable at all.
Thank you. Yeah, I think that point is very in there. Dr. Prasad, yes.
Yeah, the reason why I knew that keeping a wire would have been more dangerous, and the issue is that because there was a left main dissection, and which was also dissecting into the circumflex, I wanted to protect that circ while I did the rota. And the plan was, because we would get the rota beyond that wire because it's roomy, and try and get it just to protect it. Like you said, definitely if a wire, it'll cut it. But this was just to try and do the rotablation and protect. But I've never had any experience of doing rota with another catheter in place. So point well taken.
And like you said, this is just to make a rota. 7 French will not take a rota and any other.
That I realized. So that's correct. I would have to be about 8 French or above.
And especially even when you're retrieving the burr, you on Dynaglide, you can inadvertently cut the catheter in the guiding also. So because it's a lot of times, especially in the loop of the catheter, the burr gets a little stuck. Experience it when you try to remove it. You have to give a little more pressure to get the burr out, especially in the secondary loop of the primary loop of the guiding catheter on the left. So that's where the wire, the microcatheter and the thing can come in contact, and you may just cut it off.
Yeah, basically, I think we should not be putting another catheter or a wire into the same guiding whenever a rotablator goes inside. Thank you very much, Dr. Prasad, for this very interesting